some useful information to revise this matter with you, and that would be a good compensation, I think, for not being able to come here. Scoliosis in general is defined as a coronal spinal curvature of at least 10 degrees with rotation of the vertebral bodies. This is the common definition for scoliosis. But we have to note all the time that it's a three-dimensional deformity. It's not a lateral curvature. It's a lateral curvature with some rotation. So usually it's a three-dimensional thing. And this is the bending test that I'm going to show you. But I'm putting this to see that even if you have this cut to the thoracic cage, you can see the amount of rotation that can cause this clinical picture. But let's concentrate on the adolescent idiopathic scoliosis that we are going to talk about today. It's the idiopathic scoliosis in children from 10 to 18 years. And it's the most common type of scoliosis. The incidence is 3% for curves between 10 to 20, 0.3% for curves more than 30, so the severe cases are less frequent, thank God. For the curves more than 30, females to male ratio is 10 to 1. But it's 1-to-1 male to female ratio for small curves. So females are taking the whole burden of the severe kind of disease. And the right thoracic curve is the most common. The pathophysiology, there are a lot of theories what is really causing this idiopathic scoliosis, but you can say that it's not known. The theories could be brainstem problem, proprioception disorder, hormonal, which is some high mixture of how melatonin will work with calmodulin and the effect of that on platelets. It's highly complicated and it needs almost a day to talk about it. And also the abnormal development of the neurocentral synchondrosis, which is this area, which is a cartilaginous plate that forms between the centrum and the posterior arch. And it closes in the cervical area at around 6 years, 12 years for the lumbar, and 14 to 17 years in the thoracic spine. And any abnormal development around this area can cause this scoliosis. And in most cases, there is a positive family history. Sorry again for all this voice problems. Prognosis. The natural history is that there is increased incidence of acute and chronic pain in adults if it left untreated. That's why it's important to talk about it and to try and treat it. And curves more than 90 degrees are associated with cardiopulmonary dysfunction, early death, pain, and decreased self-image, which is a real huge problem with a lot of psychological problems for those kids. Curve progression, we will talk about this later, but the more the curve, especially before skeletal maturity, if it is more than 25 degrees, it tends to progress. And after skeletal maturity, there is no much progress. For curves that are more than 50 degrees, it's about 1 to 2 degrees per year. And for lumbar curves, more than 40 degrees would have the same progression rate. Risk factors include also remaining skeletal growth. The younger the age, the more signs that there is still more growth to come like riser sign, open triradiate cartilage, the more chance for progression of the curve. And the peak growth velocity, which is one of the best predictors for curve progression, it's for females around Manoeuvres K. And if the curve is more than 30 degrees before peak height velocity around the age of Manoeuvres K, it's more likely to need surgery. Also, the curve type, the thoracic is more likely to progress than lumbar, and the double curves are more likely to progress than single curves. And we are going to know what these curves are about in a few seconds. There are some important definitions that I have to give. First of all, what is a structural curve and non-structural curve? Structural curve is the fixed, non-flexible, and the one that fails to correct with bending. Non-structural curves are not fixed but flexible and readily correct with bending, even if partially. How these children are going to be presented if there is effective school screening, this is usually the case. And physical examination will tell you if this is a scoliosis related to like limb length discrepancy, or it is a real fixed curve with the special tests like the Adams forwards bending test that appears here when the deformity increases and the discrepancy between the two parts or the two halves of the chest wall appears like a hump, like here. That indicates that this is a fixed curve or structural one. There are other important findings on physical exams. You have to look for leg length inequality, because this could be the reason this girl or boy are getting scoliotic in order to let one short limb to reach the ground. Midline skin defects, because it could be a part of spinal dysraphism. Shoulder height difference, truncal shift, that denotes decompensation of the curve. Rib rotational deformity or rib prominence, because this is usually the most disfiguring, and that's why most of the girls at that age look for surgical management. Waist asymmetry and pelvic tilt. Café au lait patches for fear of neurofibromatosis. Foot deformities, because it's common and suggests neural axis abnormality. And asymmetrical abdominal reflexes, because then you need an MRI to rule out syringomyelia. So again, between these two end vertebrae is the famous Cobb angle that measures the angle of scoliosis. This is important because your red line here is usually 40 to 45 degrees. That is the red line between intervention and non-intervention. And then you have the so-called apical vertebra, which is this, the apex of the curve, which is the disc or vertebra deviated farthest from the center of the vertebral column, which is this central sacral vertical line. So this is the apical vertebra. And then you have the neutral vertebra, which is rotationally neutral. So here, this is the neutral vertebra, when the spinous process distance to both pedicles is equal. So this is the neutral vertebra. And then the stable vertebra, which is the most proximal vertebra that is most closely bisected by this central line. So this is the vertebra, most proximal vertebra, because these are bisected. This one is bisected again by the central sacral vertical line, but this is the most proximal that is really bisected. So this is the neutral vertebra. So these are very important definitions. The lateral exposure is very important as well. In order to have these parameters, these are very important. The pelvic incidence, the pelvic tilt, the lumbar lordosis, and the thoracic kyphosis. And you've heard during this course about these parameters. I'm not going to repeat this. There's no time for that. But these are very important diameters that have to be taken in consideration because you need a balanced spine at the end of your treatment, whether it is operative or non-operative. So these parameters are very important. What are the indications of MRI? You don't need MRI for everyone. You need it if there is atypical curve pattern, for fear that there is some neurological significant neurological abnormality as well, rapid progression, excessive kyphosis, structural abnormalities in other parts of the body, food deformities, asymmetric abdominal reflexes for fear of syringomyelia, and these are the indications of MRI. And it should extend from the posterior fossa to the conus. The classifications serve the purpose of being effective methods that I can describe the deformity to some other surgeons or parents or family or put them in the record, but also they should guide me to the treatment plan. So this is the King or the King and Mu classification, which is very simply, I don't use it that much. I use the other classification, the Linke classification, but it's the first 4 types are describing the curve when it is either single thoracic, this is type 1, the fixed structural one, or double thoracic, so 2 curves in the thoracic area that are really structural, or double major, one is thoracolumbar and the other one is thoracic, or triple curves, okay? And these are the first 4 types. What is the difference between A, B, and C is this mid-sacral line and how much deviated is the lumbar spine from it. So this is A, B, and C. What are the type 5 and type 6? These are the ones with the curve in the thoracolumbar or lumbar area only, and they are all type C because they are deviated from the midline. The Linke classification is I think, the most useful in my hands. It takes in consideration 3 parameters. The label primary curve, so it's doing the same as King's, and then assign lumbar modifier, and then assign sagittal modifier. So this is the step 1. Step 1 is seeing where is the real non-flexible curves. So I'll give some examples to be able to classify. For example, main thoracic curve is happening in all types from 1 to 6, except in type 5, where the real structural curve is in the thoracolumbar area. Let's take, for example, when the major curve is in the proximal thoracic and main thoracic, so it's double thoracic, so that's it. So it's, even if it's present in the thoracolumbar area, it's going to be compensatory to make the patient able to look forwards. So this is the first thing in Linke classification. Then the next thing is the lumbar spine modifier, and the steps of doing that to classify is very simple. First of all, you have to identify where is the apical vertebra, and we've talked about the apical vertebra. So here, this is the apical vertebra, and then take this central sacral line. And if this central sacral line is passing between the pedicles of the apical lumbar vertebra, so it bisects it, that's A. If it just touches one of the pedicles, it's type B. And if it is not touching it at all, it's type C. Then we have the thoracic, which is the sagittal thoracic measurement. It's the Cobb angle that we have just described between T5 and T12. If it is hypokyphotic, which is less than 10 degrees, normal 10 to 40, and positive sagittal thoracic modifier if it is more than 40 degrees. So treatment is based on all this, on skeletal maturity of patients, magnitude of deformity, curve progression. It could be non-operative, bracing, operative like posterior spinal fusion, anterior spinal fusion, anterior and posterior spinal fusion together to prevent the so-called crankshaft phenomena that I'm going to describe in a few seconds. Bracing, I have a personal bias here. I'm not a bracing guy. I don't use much bracing. For the curves that are having some flexibility, I use physical therapy more. And I think bracing is causing a lot of psychological problems for those kids, and that's even more dangerous than what scoliosis is going to do for them. But those who use bracing, I don't use them. Recommend them for 16 to 23 hours per day. So put yourself in the place of those kids having to put this all this time. You must get psychologically disturbed. And they use braces like Milwaukee, TLSO, Boston, Charleston bending brace. I'm not a big fan of those, and I'm just going to give definitions they put for their success. Bracing success is defined as less than 5 degrees curve progression every visit, and the bracing failure is defined as 6 degrees or more curve progression or orthotic discontinuation, and this is what usually happens. And it can happen also with skeletal maturity, so you have to see where is the skeletal maturity to stop bracing. And usually they are used for curves that are less than 40 or 45 degrees if they work in their hands. I'm more advocate for surgery, posterior spinal fusion. Let's talk first about the fusion levels, and then we'll talk about the maneuvers. What are the goals? Our goals is fusion should include enough levels to adequately maintain sagittal and coronal balance while being as minimal as and as safe as possible to preserve motion or to preserve enough motion in that spine. Typically, fusion is happening from invertebra to invertebra, but it depends upon what school are you going to align to. Harrington recommended 1 level above and 2 levels below the invertebra if these levels fall within the stable zone. Moore technique recommended fusion to the neutral vertebra. We have described that. Linke recommended including all major curves in the fusion and minor curves that are not flexible or archifotic. Cochrane reviews said that stopping at L5 and L4 to a lesser extent is not giving favorable results. So in these cases only, you need there's another one coughing in the room. That's perfect. I've infected someone. Yes, I'm talking about you. This is one of my assistants in the studio. If you have to stop at L5, it's better to go to the pelvis, like I'm showing you here, to the iliac spine, to the iliac bone, and to a lesser extent to L4. But for myself, if I need to extend to L4, I go to the pelvis, and that's another personal bias. Curve correction is done by a lot of maneuvers. These are the reduction maneuvers: distraction compression, simple rod rotation, simultaneous rod rotation, rod translation by persuaders, direct vertebral rotation, cantilever bending technique, and vertebral co planar alignment. This is an example of correction only using compression and distraction. So you're going to compress the convex side and distract the concave side. And this is another method. After application of the screws, you apply, you contour the rod into the proper alignment, like this, and then put it in the deformed position. And then the whole rod gradually until it comes to the corrected position. Also, you can do this segmentally by use of these towers to segmentally derotate the most rotated segments. And this is a very effective method as well. This is again compression section. And you can put the rod and then bend the rod itself. I'm not a very big fan of this cantilever bending or in situ bending. Maybe to do some fine tuning, but not to do the whole maneuver because of the decrease in the pull-out strength of the screws using this method. You can translate the rod by persuaders to be attached to the screws, and this gives a translation of the spine towards the construct, and then the vertebral co planar alignment when you put the screws on both sides, and then put the towers on one side, connect them to a polyethylene rod which is strong enough to align the spine, and then put the rod on the other side in the corrected position, and then put another rod on the other side later after removing these towers. We have anterior spinal fusion and instrumentation. It gives better correction, saving more segments from fusion, but increases the risk of pseudoarthrosis and increased thoracic hyperkyphosis possibility. And there is a technique that's gaining popularity now, which is tethering the convex side, putting the screws like this. These are anterior screws because when you have this anterior approach, either transpleural or retropleural, you put these screws from side to side to the vertebral body, and then they put like a polyethylene tube that connects these screws together, and then compress this convex side. So it's a kind of growth modulation with the convex side vertebral body compression, and then wait for skeletal maturity, and then remove your implants. Neurological monitoring, it's becoming either the somatosensory evoked potential or motor evoked potentials. It's the standard of care. Neurological event defined as drop in amplitude to less than 50%. If neurological injury occurs intraoperatively, consider check for the techniques, your screws, check the blood pressure, hemoglobin, lessen or reverse correction, and do Stagnara wake-up test, which is the golden standard. And if not, remove the instrumentation if the spine is still stable. Complications, neurological injury, paraplegia in 1 out of every 1,000 cases. These are the statistics of the United States. In the Middle East, we don't have enough statistical data for that. There is increased risk also of kyphosis, excessive correction, and paraplegia is more happening if you're using sublaminar wires because you're intra-canal. Pseudoarthrosis in 1 to 2% of cases, infection 1 to 2% of cases. Flat back syndrome, which is giving the patient real hard time with need of revision surgery with osteotomies. Crankshaft phenomena is a rotational deformity of the spine created by continued anterior spinal growth in the setting of posterior-spinal fusion only. Can occur in very young patients with only posterior-spinal fusion when performed alone, and the anterior column is allowed to continue its growth. And it's avoided by performing anterior discectomy and fusion with posterior fusion in very young patients. Superior mesenteric artery syndrome, which is a compression of the third part of duodenum due to narrowing of the space between this superior mesenteric artery and the aorta. Usually it's temporary and presents by symptoms of bowel obstruction in the first postoperative week. and it's treated by IV fluids until it goes away. Also hardware failure and rod breakage that indicates pseudoarthrosis. And by this, I thank you so much, and I'm waiting for your questions.